Thank you, Maria. I hope you see my slide.
Yeah,
and
perfect.
see also my next one, where I say that I have no conflict of interest. Well, first of all, thank you for inviting me. It's really a pleasure for me to be here to see so many young people and young physicians, I would say, because the average being in epidemiology, I would say, is quite low in the audience of this conference. It's not easy for me to talk about numbers, especially after Karen's speech and with you, because numbers often are perceived very far from, the everyday life and organization that everybody of you have to face or have to address. But I really hope that I will be able to provide some numbers that could help, okay, in advocating, as Owen also said at the beginning, okay, for, making changes in terms of policy and organization. So let me start to say that I will use throughout my presentation the comprehensive definition of adolescents and young adults, which is the one that is currently recognized in the US by the National Cancer Institute, and also, in Europe by the SIPIR committee, but also by the AYA working group of the ESMO and SALPI. We know that there are different definitions of AYA with difference, especially in the upper age group. But this is the one that I would use because, first of all, it will allow me to much easier compare different studies. And this is important if we want to be credible in terms of number and in terms of the burden that these tumors may represent. So the first topic I really would like to address is why eye cancer matter. Globally speaking, and then of course I'll go into the European perspective, eye cancers, and I would say this is a good news, are rare cancers, so they are not a lot. And this is a good news because we know, and you know better than me, what this implies for patients that get a diagnosis in this age group. But the data that I think is really important to stress is that adolescents and young adult cancers are ranked fourth in terms of cause of death when we are dealing with cause of death for adolescents and young adults. And this is a big issue because, of course, although they are rare, they are one of the most common cause of death in this age group. And we know that this is an important age group, not only, for the family and for the friends, but also for the community, because they represent really, the investment also for community and social for the future. What is of interest is that they are the fourth cause of death. And if we look if we consider how this change accordingly to the social demographic index, we immediately realize that when we deal with adolescents and young adults, what is important is, of course, economic development, education, but also fertility rate. And that's why I think that being rare, it's important to consider not only the European, but the global perspective, because a lot is changing and, fertility rate changes. And it is clear that, all over the world, adolescents and young adults will face the same, if not even worse problem. Just to give you an idea, globally, childhood cancers are ranked the 10th cause of death for childhood. So you see that here we start seeing, specificities of AYA. So they are rare cancers, but are one of the most common cause of death for this population. From an epidemiological point of view, but I'm sure also from a clinical point of view, Maria said earlier on that here there are adult oncologists as well as pediatric oncologists, because it's true, everybody knows that adolescents and young adults have a really, a peculiar array in terms of cancer distribution, because they share the cancers of childhood, but also the cancers of the adults. But of course, there are also some tumors that are really, we say the incidence peak, so are very, very, peculiar in adolescents and young adults, like, for example, the testicular cancers. And of course, what makes the epidemiology of adolescents and young adults cancers, in a certain sense, difficult is that When we start looking at the cancers that arise in these populations, they differ accordingly to the different age group. So they differ as age increases from adolescents to young adults. And they differ also between males and females. So they are rare, they are many, they are heterogeneous, they are different across the age, they are different across gender, across sex. So it is clear that here we really need to come together to properly address, okay, the peculiarity and the differences of these tumors. From an epidemiological perspective, for us to talk about cancers in AYA, exactly because there is this heterogeneity of cancers, doesn't mean a lot. That's why we provide general estimates in terms of incidence and survival or mortality. But then if we need to inform clinicians, if we need to inform needs, we need to handle, okay, the rarity and the heterogeneity of these tumors, which, because are rare, it's an issue because we have few numbers. And we can immediately see how much this can be fair, because, for example, in females, as age increase, of course, we will deal with thyroid, breast cancers, whereas in males, we will deal mainly with testicular tumors. So when we are dealing with a female adolescent and a female young adult, we are dealing with a person with a different type of tumors. This difference between females and males is so big that Michael Vaccarella actually raised, an important and interesting question. Is there a gender inequalities in terms of burden in adolescents and young adults? And these arguments are quite interesting because if we look, okay, in females, you see that basically, regardless of the Human Development Index, which is an indicator of the development, which again goes back to income, education, we see basically that breast cancer, for example, is among the most common tumor. Now, pay attention, because if you look at the rates, you see that the bars for females have reach hundreds, while the one for males reach 50, okay? So you can immediately see, in terms of incidence and therefore in terms of the number of cases, those in females are much higher, okay, than those in males. Of course, these are due to breast cancers across, the different type of countries and across the different economy. The next one, of course, will be the cervix cancers. And we know that when we deal with cervical cancers, there is a lot of prevention that can be done, okay? There is a screening, there is a vaccination, and we know also that behind cervical cancers, there is a socioeconomic pattern, okay, that we can envision within Europe, but also, globally. So there could be a lot of inequalities in terms of the burden, in terms of the incidence of these tumors that is, preventable. Thyroid, tumor of thyroid, is the other one you can see. This is really, common in female, especially in high-income countries. Europe is one of these, but also, South Korea. And of course, here we're dealing with overdiagnosis. So we are diagnosing tumors that might not lead to death, but might lead to overtreatment, and therefore to long-term impact of the treatment. So you basically see that as Vaccarella was basically, questioning, thyroid, breast, and cervix cancer really, might represent a big burden, okay, a preventable burden. That probably, is something we can start thinking about. The other questions that I'm sure will be addressed in these 2 days is, of course, why cancer survival for the same tumors, differ between children and adolescents and young adults. These are the Eurocare study that dates back to 2007, but still, we are now analyzing the updated data. And for example, for soft tissue sarcoma, situation didn't change. You know better than me that especially for acute lymphoid leukemia, acute myeloid leukemia, but especially for soft tissue sarcoma and rhabdomyosarcoma, we know that survival of children is much higher than the one that we observed for adolescents and young adults, but also, you know, in the different age group. So why this happened? I often discuss this with Andrea Ferrari, who is present here, because we really joined forces to properly, you know, interpret differences in survival. So is the place of treatment important? Yes, it does matter. This is a study that we performed in Italy, where we tried to assess the volume of the hospital in which adolescents with soft tissue sarcoma was treated. You can see that here we have approximately 400 adolescents with soft tissue sarcoma in 8 years, and you can see that 800 patients in 8 years are basically treated in about 100 different hospitals, with only, okay, a couple of these hospitals having, you know, a volume that justify expertise for treating these patients. So there is clearly an issues of the referral, which basically imply where these patients are treated and how we can ensure that, you know, a better referral to expert center is ensured at national and at European level. Is the type of treatment important? It has been very well known and proven, for example, for acute lymphoblastic leukemia, the importance of treating also AYA with childhood protocol. This is the same example and rationale for rhabdomyosarcoma. We did a population-based studies where we basically collected information about the type of treatment for adolescents and young adults. We had information also about the aggressiveness of the disease. And basically what I'd like to stress is that even when we adjusted, okay, for the different treatment received, what we basically realize is that treatment, so even if adolescents are treated with pediatric protocols, these help contribute to explain the survival differences, because we realized that adolescents treated with pediatric protocols have a lower risk of death. But the treatment alone and the place of treatment doesn't explain completely the different survival. So the hospital of treatment do matter, the type of treatment do matter, but there is something else that, you know, we still have to understand what is it to properly explain differences. So having the fortune, I would say, our institute, it's a cancer institute that treats both children, adolescents, and adults. We manage for some samples, you know, to have samples across the age spectrum. And so we really started to address whether it's a tumor biological differences across the age group, but what colleagues more expert than me, because I'm only an epidemiologist, what they are really questioning now is that probably, you know, there is an important host factors that can really, you know, help in understanding the reasons for difference. And if you think, we clearly know that an adolescent differs from a children and differs from a young adult or a person of 30 years old. So the host role is something that now is considered a very promising path to further explain. So in brief, if we want to explain differences in survival, we really need to have a 360-degree approach that goes really from the bench to the public health, if we want to understand also the impact that healthcare system can have. And I'd like also to stress, since we have also adult oncologists, that differences in survival exist also between adolescents and young adults with adults. So we know that, for example, breast carcinoma, colorectal, prostate, and lung, for these tumors, you know, adolescents and young adults have a worse survival than the one compared to their adults counterpart. Here, there are more available already biological explanation, but this is, of course, a matter that we should not forget when we stress differences in survival and specificity of survival for adolescents and young adults. This is really the most important message that I want to give with this slide, because our colleagues and friends, I would say, in 90s, you know, they reported in the US a lower rate of improvement for adolescents and young adults in terms of survival in comparisons to children. Well, we decided to join forces together, and we basically compare trends in survival in Europe and the US for children and for adolescents. We selected only the tumors that children and adolescents had in common. We basically so what you see here is the observed overall survival, but then you see the APC, which basically is the annual percent change, gives you an idea about, you know, how much the survival change on average annually, and you have also the P to really understand whether there is a significant difference. So you might wonder, okay, here there was a huge increase, but this was not statistically significant. So if you compare basically the survival over time, so the trends in survival in Europe for children, you can see that the average percent change between, you know, the 80 and the 90 was very similar between children and the adolescents and AYA, 1.78 to 1.88. After 90, so from 90 onwards, you can see that adolescents and young adults had an higher, survival increase than children. The situation in the US was slightly different, and that's why, you know, Blair basically came out in the 90s with the idea that there was, you know, a lower rate of improvement for adolescents and young adults. But, okay, this was not the case in Europe. And also the latest survival trends for adolescents and young adults confirm that survival is improving. When we try to explain why this was happening in the US, we really realized that the major reason for which they were observing this difference was the acute lymphoid leukemia, and an issue especially for young adults in getting access to pediatric protocols. These are further analyses that we did. But this is an important issue because often I hear this as an argument, for discussing AYA, and I really wanted, you know, to give evidence about that in here, Europe and US do differ. And I will end, or I will go towards, you know, the end of my presentation, because I'll be happy to hear also from you, showing two important aspects. Adolescents and young adults cancers have different incidence across the different European member states. And I will show you that they have also differences in survival. This is a big issue that I think a collaborative, you know, network and effort like the SALP committee and the ESMO SALP committee, you know, really should consider to address. When we try to understand what matters, what is behind these differences in incidence, most of these differences are due to female breast, thyroid, testicular, cervix, uteri, and melanoma tumors. So we are dealing with type of cancers that, of course, are more related, you know, to the young adult type of phase. There is a lot, you know, in terms of overdiagnosis, in terms, as I was explaining earlier on, of availability and access to screening and vaccination, different lifestyles. For melanoma, it is very clear that there are differences due not only to different behavior, but also now there is an hypothesis that obesity can represent, you know, a risk factors contributing to explain the increasing in incidence and also the differences in survival. For testicular tumors, of course, here the history it's longer. We know that there are different hypotheses that were mainly due to cohort effect. and other possible explanation. It's still not clear, actually, how to what we can attribute differences in female breast. But what is important, and you can see from this graph, is that there are really, countries in Europe where the mortality is pretty high. Okay, I started saying that this is the 4th cause of death globally, but you can imagine, you can see from this picture that in some countries, mortality is most likely, too high than what is deserved for these tumors that for which most of them are curable. Why all these matter? Because basically, I said that they are rare, but they are increasing. The incidence, it's increasing for most of the adolescents and young adults cancers. And that's why I think that together we should join forces. And I hope this data will be of help for putting, AYA as a priority at national and European level. And of course, I'm more than happy to hear from you and answer to your question.